Thanks for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar, frequencyspecific.com/about, or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
I'm all by myself. I should talk about the Ehlers Danlos patient. We're having technical. Did I mention that Mercury's retrograde? Please do. Ehlers Danlos patient. Well, her major complaint when she walked in was anxiety and digestive difficulties. Okay. And what does that make you think of? So the first thing I had her do was put her hand on the table and lift her little finger up. And it went to 95 degrees. And then I had her straighten her elbow out. And she said, "Why are you doing that?" I said, "Just wait." And I got the long goniometer out. And she was -5. So her elbows went backwards 5 degrees. Her knees went backwards 5 degrees. So yeah, I know. Yes, leaf, carrot, high leaf, and no candle. Because her computer is... Did I mention Mercury's retrograde? It's not my fault. Or her fault. Anyway, and she said, I sprained my ankle, and her pain is in her shoulders and occasionally in her knees. And did I mention I sprained my ankle? And it's, yeah, you see your elbow and your finger, and her thumb didn't go to her wrist. She said it used to, but it doesn't now. And then she could bend over and put her hands on the floor. And I said, "Great, you are? Huh? What's that?" So I had to explain to her what happened. And so I ran 40 and 10 for the body pain she didn't know she had, and then concussion and vagus for the digestive difficulties and the anxiety, because inflammation in the brain caused by the vagus not working is the major symptom is anxiety and depression. And if you read about Ehlers Danlos, it's part of the diagnosis is there's a psychological profile that goes with Ehlers Danlos, and that psychological profile is anxiety and depression. And then 40 and 10, and then 124 and 77. And then this is a girl that has taught herself to meditate just to deal with the anxiety. And so as I set everything and turned everything on, she just closed her eyes, and you watch, those of you can see things like that, she just floated right over her body and up into the corner. I said, this works better if you stay in your body. And she went, "Okay, I'll try." And so she got a little closer, but that's something you don't want to tell people that you're aware of. Creeps some people out. An hour later, she finished, and her little finger was, and the other condition was chronic constipation. So her little finger stopped at 70 degrees. So at first she said, "Oh no, it's still at 90. And it's, "No, you have to put your hand on the desk." And then raise your little finger, and then it stopped at 80 degrees. And her elbows were 0 and her knees were 0, and she couldn't touch the floor. So that took her down. And I said, "How's your anxiety?" 0 to 10. And she said, 0? 0. I don't. She's been anxious since she was born. So she doesn't know who she is if she's not anxious. I said, "It's okay. You'll get used to it." So I have her here for the week, and her mom is taking very good care of her. And her mom is going to get her custom care on Friday. So when you program it, they don't have 3 custom cares they can run all at one time. When the anxiety comes back, you do concussion and vagus. When your body sort of aches, you do 40 and 10. And when you can put your little finger on the table and your little finger goes to 90 degrees or more, then you run 124 and 77. And that's it. There's just no thing. The other patient that was in the office with her was her mom. And her mom had what's called Cavernous Hemangioma. So hemangioma is like a cluster of blood vessels, they're all lumped together. They can happen anywhere, in your liver, or spine, or bone, any place. Cavernous hemangioma is a hemangioma that's got like a hollow thing in the center, and it's pretty big, relatively speaking. She said it was Ellis, and she had full body pain. And so the last time she came, and she had a stroke. And then she recovered from the stroke, and the neurosurgeon said, we should take care of that cavernous hemangioma that's left, because that could go any time. So she recovered from the stroke. But the surgery that he did for the remaining cavernous hemangioma didn't go well. It took out everything from the thalamus forward and out, worse on the right than the left. And so I texted Ben Catholi and got George's experimental list for the cranial nerves, because everything was affected, from the muscles that move her eyes to the facial nerve to the trigeminal nerve to full body pain because it was in the thalamus. So we did 40 and 89, and I used the experimental frequencies and got the spasticity out of her face. That was pretty exciting. And then the thing that showed up yesterday, instead of having pain down the right side of her body, because it was a right-sided cavernous hemangioma, she did bring an MRI of her brain. And there it said, there's the cavernous hemangioma in the pons. Her legs were tight. Her body was tight. The right side of her face was tight. It's the right side. But her face was tight. And the only patient I've ever seen with a stroke in the pons had full body spasticity. So the stroke was in the pons on both sides, like that. And she would look at the anatomy, and the pons are these two little structures right next to each other, and she had a stroke that took out both sides. And so this kid was almost nonverbal and very spastic. And this was a Cleveland Clinic pediatric rehab. And we ran increased secretion. What's wrong with the pons? It's not secreting what it's supposed to secrete to tell the body not to be spastic. And increased secretions in the pons, and spasticity reduced from the top down. Now remember, when you run increased secretions, cavernous, you got that right, Louise? Cavernos, hemangioma, Hemangioma, I think. So, when you run 81 and 10 for spasticity that comes out of the spinal cord, some parts of the brain, and it relaxes up the front, from the bottom up, and then from up the back, from the bottom up. Okay, this one, running increased secretions in the pons, the spasticity reduced from the top down. Wouldn't you like to know what we're doing? That would be really fun. I just can't get my head around it. It's like, how do we do that? How does that work? Why does that work? That's been my week. There's another patient that I couldn't figure out. After the birth of her third child, she all of a sudden started losing weight. And her normal weight was 120. Her whole family's slender, so it's normal for her. She's 5'6", 120 pounds. That's pretty slender. But she's down to 87 pounds. It's not cancer, because her daughter's 21. If it was cancer, she'd be dead by now. And she was sent to me as a cervical trauma fibro patient. She doesn't have full.
There's she now.
You can.
Computer is just not working, but I'll just set it up and hope for the best.
Okay. Let me see if I can pin you so we can. Where'd you go? That's how do I pin her, Kevin? This is. Hang on. Pin you. Yeah.
I'm so sorry. I don't know what is going on, but I'm here now.
The thing is, you don't have Kevin to stand there next to the computer and scare it.
I was trying.
He was trying.
I felt it. Internet gremlins. That's exactly what it is.
Exactly.
Okay, I'll try to keep my phone.
Finish telling the story that just he was as a cervical trauma fibro patient, and she doesn't have full body pain. The only thing she has is pain in her spine. The naturopath who referred her understands fibromyalgia from spine trauma. And the patient had asked her if she had body pain. She said, no. Really? What does hurt? Just my spine hurts. So so this lady has lost 25, 30 pounds. She weighs like 94 pounds. And she's 5'6". And she's not slender and muscular like you are. She's emaciated and so sensitive she can't take supplements. And everybody, including the person that referred her to me, puts her on them. Oh, you shouldn't eat these things. This is why you're having problems. You shouldn't eat that. Well, now what can she eat? I don't care. You put something in your mouth every 2 hours, and preferably something with a lot of calories in it. Coconut cream, whipping cream.
No.
I don't care. Just some
Get it
in your mouth. And so that's my mystery patient. And she was sent to me because she had cervical trauma fibro. The only thing that hurts is her spine. And I said, do you have osteoporosis? Oh, yeah, I have that too. And when is your spine pain the worst? When I lay down in bed. She's had this for 10 or 12 years because it was after her daughter was born. So it can't be bone mets or her pain would be higher than a 6. After 17 years, the primary cancer would have killed her. If it was bone cancer, that would have killed her by now. She'd have pathologic fractures. I have no idea what she has. And anytime you work on her neck, she's great for about an hour, and then she gets serious disequilibrium. Nobody has done flexion extension x-rays. I love having a referral practice, but folks, imaging is your friend.
Yeah. And I guess that's where I have a hard time when that's not done first, because to me, that would have been the absolute first, safest, most effective way to start.
Flexion extension, full series of x-rays. And I want an x-ray of your spine. Now, we don't do full spine films because they're diagnostic, even though it's a chiropractic. Then I said, what's your bone density? Oh, I have that osteoporosis thing. Yeah, I have too. Okay. So I run in concussion in Vegas. She's chronically constipated, but you can't even find her sigmoid colon. There's nothing.
Wow.
She can't eat any fiber. Oh, you can't eat oats because that might be wheat. You can't eat this. You can't eat that. And then Saudi told her, oh, you can't eat oxalates. That takes out a huge chunk of any food she's allowed to eat. She's dangerously underweight. Like, we're talking Dachau, Auschwitz underweight. And all they can tell her is, oh, it's your stomach hurts because you're eating that food, so you gotta stop that food too. That was my week. How was your week? Better, I hope.
I've been riding the high just on a personal level. I ran the San Francisco half marathon on Sunday morning. I did the double up challenge. So I actually ran a different race Saturday. I ran just a 5K Saturday and then the half marathon Sunday. It was the biggest race in San Francisco history. There was over 35,000 runners. It was such an amazing environment to be a part of. And the only thing I can compare it to is our FSM meeting every year, is when you're just surrounded with that really good camaraderie type of energy where everybody is just positive and cheering for each other. And there's really nothing like a really big race that's chaotic and crazy. I ran it the last time 6 years ago, and I beat my time by over 7 minutes, which is amazing for a very challenging race. So I've just been very happy ever since. And I also have a little bit of the post-running blues because that was the kind of last race on the calendar for a little while. Just have to find another race.
What's a COMT to do?
Oh, okay. So this is when you're running for 2 hours, you have a lot of time on your hands to think about things and to work through things in your head, our problem-solving skills with our 7 S's, thinking about patience. But I was also thinking a lot about just when you have that hypothesis, when you have that idea in your head, and when you're running a race, you have an idea in your head how you would like to run it. I would love to run the second half faster than the first half. That's my strategy. However, when there's a lot of hills in the middle of the race, you have to adapt and pivot and know that you can't run just as fast up the hill as you're going to run down the hill. There's going to be ebbs and flows. And I really do think about how I strategize differently now with patients. And I've had a lot of new patients in the last little while, and they all want the plan. How often do I come and see you? And what should I expect? And what's this and what's that? And I said, ideally, I would like to see you twice this week and so on and so forth. And we put together the strategy of how they're going to come in. And then the expectation conversation happens. And I've even found that has dramatically changed in the last few years because I used to, and I still do, we still want to see a reduction in pain. That is obviously one thing that we would really like to see with everybody. But sometimes you have to have the conversation that the pain is going to change. And the pain in your knee may be gone, and then maybe you find something else comes up in your hip, or maybe you feel it in your foot, or maybe the pain doesn't feel sharp and bright, and maybe it feels more dull and achy. And all of that is okay because it means change is happening. And I think as long as we can have that open and honest conversation, I think that really will help build those reasonable expectations.
Well, and the concept, they think they just have knee pain. You start working on their hip and you tape their ankle and you do a drive-by on torn and broken and the meniscus, and now their knee feels better. But why did you do that to what am I fart? What? Huh? And explaining to them that this is connected to that. And when you work on their hip, by the way, your shoulder is going to have an opinion about that in 2 days, but we'll talk about that in 2 days. And they go, what are you talking about? It's because that is connected to that, is connected to that, and that's connected to that, and that's connected to that. And that's why I'm going to see you twice a week for 4 to 6 weeks. It's like expectations. Good topic.
I think it's helpful, especially for the people, you talk about the COMT people, but the people who are really hardwired to move and move a lot and sweat, and the injury maybe isn't debilitating, but to them, it's limiting enough that it is changing their life. And so I also think about this, the whole spectrum of patients that we see. You see some of the very thick, debilitated, challenging, head in your hands, what do I do patients, but that their urgency or their desire to get better is just the same as my professional or elite athletes that are trying to change, like all their energy that they're pouring into to change a second, a fraction of a second. And it's the sum of all the parts that we have to try to put together. And again, that kind of goes back to that stable state slide that really, if anything got to me that first core, I think it was the stable state slide, because it's such a important reminder that us as practitioners are up against quite a bit. And as amazing and as magical as FSM is, you're not going to change an anatomical short leg or a diabetic or a smoker or an alcoholic, or the list goes on. So just dealing with the material that's in front of us, and again, going back to expectations and really clear, kind of truthful conversations is such an important foundational starting point, I think.
And there was a thing that happened to me last night when I left the clinic after talking to this lady with cavernous hemangioma. Her MRI shows the neurosurgery where he went in to take the cavernous hemangioma. The MRI that she had done shows it's still there.
Wow.
The lady I saw last week has a genetic condition called SPG7, where the mitochondria in her nervous system, it's in the spine, and then it moved up to the brain. And she had foot drop in the right foot, and the right foot is actually better. The braces now get in her way. The left foot everts. So I had to tape it so that it didn't get in her way when she walked. And then this lady with the cavernous hemangioma stroke, Pons stroke. I went home with this ache in my chest. And it's like, you fixed your daughter. What is this grief about? I'm not having a heart condition. My heart aches. Why is that? And it's because they can't be fixed. I can't, and they come to me looking to be fixed. FSM has now arrived at the point where there are people that are going to walk into everybody's office, and yours, Catherine's, Annie, Danielle, everybody's. You're going to get those patients. You're the court of last resort, and they have something that is not fixable. You can't put tissue back that's not there. That being said, this lady with this Pons, now that I know it's the Pons, I can change the spasticity on her right side by treating increased secretions on the Pons. Now that I saw the MRI, some of what she has is not fixable. Trigeminal nerve, nice experimental frequency, thank you, George. But I can't put tissue back that's not there. Nerves in the brain don't grow back. We can't fix them the way we can fix peripheral nerves. And there was this, I'm going to have to do that now that we have 4 days at the advanced. One of those afternoons, I'm going to take an hour, and what I didn't tell you, what I can't warn people about it in the core.
No.
But what I didn't tell you, and it's just, what's interesting is for as long as I've done this, it surprised me. Because I fixed your daughter, why didn't I pay attention to the fact that this kid is now digesting her food anxiety is completely gone, her range of motion is completely normal, her body pain is zero, yay. But across the fall is this woman that is not without hope, but not fixable. I don't know. What do you do with that? What do you do with that? Did you get it?
Yeah, it is. And it is something that nobody prepares you for. And you do a good job of trying. But there is, and I think you said it with there's a connection, there's an intimacy with FSM treatment that supersedes anything that you could ever experience as a practitioner. And that is what I love about what I do. I love that connection. I love the time. I love the way I can practice now, seeing less patients in a day and have more quality time with them. I feel like for where I'm at, I need that time. I need that one-on-one, as opposed to, and I'm not discounting the fact that you can have multiple machines going in different rooms, because there's a time and a place for that, depending on the person and the pathology. But with that connection and with the stories that they tell you, they are giving, you are taking, and there's parts of it, as stoic as you try to be, clinical as you try to be, and as professional, there's a connection that happens that does keep you up at night sometimes. And how do you get rid of it? How do you deal with it? How do you sit with it is something I'm trying to figure out.
And I can't talk about it at the core, or
No.
we'd never have another practitioner.
Yeah.
At the advanced, I still remember Tammy Waller-Lee in the second row as I'm going through that slide presentation, because it was the same year you gave me that award. And I followed your presentation with the what I can tell you.
What were we doing to these poor people?
They're 70. And there's Tammy just sobbing in the sun. As that touched a nerve, because finally somebody talks about it.
I think that connection, that when it's like when you're in class and you have a question and you're too embarrassed to ask the question, and then somebody asks the question, you're like, thank God somebody else is thinking this and is feeling this way. And I feel like that was like the collective sigh of the ballroom that day is, okay, it's not just me that thinks this way or feels this way. And maybe that is part of the results with FSM, is that X factor that we are able to give our patients. I had somebody, I think I had talked briefly about it a couple podcasts ago. It was the person that I was convinced it was her neck and not her shoulder. And then finally the MRI proved what I was thinking all along. And going back to just the emotional state of somebody who has been going from doctor to PT to chiro to sports medicine, and everybody is telling her it's her shoulder. And if she just does an injection or stops lifting or whatever, it's going to go away. And it doesn't. And then you have somebody that's looking them in the eye and saying, I am listening to you. And I agree. It's not your shoulder. And we will figure it out, and we will find out, and we will prove everybody wrong. It's having, I think, the support of having somebody in your corner, somebody that's looking at you in the eye and saying, I believe you. It's not in your head. I've seen this before, and it doesn't scare me. And I will go head to head with any doctor, with any degree, with anything on their wall, and say, you are wrong. And we did. We navigated that and got the MRI that proved it was not a shoulder pathology.
Yeah.
And the thank you that I got was, thank you. Yes. Yeah. Not in your head. You're not crazy. It's not just menopause.
Yes, it's not just menopause. And there's something validating for FSM practitioners.
Yeah.
For FSM practitioners, especially in the last 5 or 6 years, since in the core and in the advanced, this is to teach you how to think. And it's, excuse me? And then The first thing is you take the diagnosis they walk in with and you throw it out. You just disregard it. So what? And then start over.
Yeah.
This lady with the really seriously underweight lady, her reflexes, who was sent in with a referral for cervical trauma fibro. Because she's 78, 70, she's my age, she's 78, almost 79. And her patellar reflexes are 0, which is normal for somebody my age. So she's not a cervical trauma fibro patient. The only place she has pain is in her spine. And I've never seen that. Think. What is it? You've had it for 17 years, so it's not cancer. What is it? What else makes your spine hurt? Don't have any nerve pain. Don't have any funky reflexes. It's got to be the bones. So I ran spine to front, inflammation in 59, 39, 15 minutes apiece, and then the periosteum. I said, how's your pain? She said, oh, it's gone. You have osteoporosis. Yeah, I do. That is not one of the diagnoses she walked in with. It was just like, oh, yeah, by the way. And there's no way to fix it. She's got her vitamin D levels up, but she hasn't been on estrogen. And yeah, and you need to gain 30 pounds in the next 2 weeks would be great.
Wow.
Or the next 6 weeks.
Yeah. And another thing I'm grateful for, like I said, I spent 13 miles thinking of each mile I dedicated to someone or something. And I'm going to post about it on Instagram. So FSM and you definitely I gave you mile 6, which was the steepest hill. So metaphorically and emotionally, I feel it was apt to put you both there. But one thing I am grateful for too is the community in which FSM has nestled itself in, because I am so fortunate that I can text a functional medicine doctor. I can text a chiropractor. I can text an orthopedic surgeon. I can text so many different people. I can text the dentist. There's so many people that do FSM that I have cultivated such fantastic relationships with. So when I am stuck, and you tell the stories yourself when you're stuck, we've got people like David Burke and Ben Catholi and David Mesnick and so many wise people. We can say, I don't know what this is, but can you help? Can you assist? What do you think? Whether it's with a frequency or somebody that can just spell out a prescription for me and what the side effects could be, things where I don't maybe trust Google to do, and I can text my...
Especially now that, has anybody noticed that Google is all AI?
Yeah.
That just drives me insane. And it's Dr. Wood Patrick said, yes, he has a copy of the 2018 Physician's Desk Reference, and he said, they are going to pry it out of my cold dead hands. And it was the last printed book.
Wow.
And it's not on the internet. It's, you get what you get from Google and AI, and you look for side effects, and it's no, just no. They leave. Where'd you go? Oops, we lost her. Kim, come back. Where'd you go? What? Hi, everybody. It's me again. Julian, congratulations to Kim on the marathon. I went to Banff National Park, did a fast-paced hike up and down Johnson Canyon to get back to the tour bus on time. My Achilles tendon started to hurt that night. It hurts when I stand up and walk. Pain goes away after a few steps. Took it easy, no improvement. It's like, really, Julian, that night, you waited 2 weeks. You just won 124 and 191 for 2 hours. Yeah, 124 and 191 for the length of the Achilles. And remember that the Achilles goes up and then it turns into connective tissue in the gastroc and soleus. So 124 and 191 for the Achilles itself.
What did I miss?
There you are.
Sorry. Well, it's something's happening with electricity today. I don't know what it is.
It's Annie described it as
Internet gremlins.
internet gremlins.
They got me today. Yeah. And it was so bizarre. I was on a Zoom this morning. Anyways, I heard something about gastroc and soleus, and you're speaking my language.
Julian waited 2 weeks, like he strained his Achilles, and he waited 2 weeks to run 124 and 191. And I was pulling a Dr. Mom on him and saying, what is the matter with you? You do it that night. You don't wait 2 weeks.
Yeah.
Just remember that the Achilles, the round part, is just at the very bottom. And then the connection to the calcaneus is 77. It's connective tissue.
Yeah.
And it goes up into this fan, connective tissue 77. And the gastroc and the soleus are held together by this band of connective tissue 77.
Yeah.
And when it's sore, you run it right away. And it's a Dr. Mom thing. I can't help myself.
No, I love it. I want to give everybody like one of the best hacks, because I'm all about the hacks and getting things done quickly. But when you're ever stumped for what kind of frequency, and especially if it's straight up like muscle type of connective tissue, if you open up Netters, and when you see the diagrams, and Netters is obviously they're sketches, they're not true cadaver pictures, but when you see the white, so you'll see the red muscle belly, and then it turns to white, and then it turns tendon. That white, especially the fan type of striations, that is straight up 77. That will always be connective tissue. So when you see that really plump red gastroc turn into the white fan, turn into the tendon, that's the muscle belly. That's 62 turning into 77, turning into 191. Like,
you have turned me into a 46 convert. I, who did not believe the 46 did anything, because I didn't believe that 47, 48, 50 could do anything. It just did. They had to have made the note. But 46, if you're treating a hamstring that's strained, you run one machine on 124 and 46, one machine on 124 and 77, down with the knee, and one machine on 124 and 191.
Yeah.
And it's multitask.
It is multitask. And there's a slide in the Sports Advance that is about 46, and I call it the Sarco something, because I do think sometimes it is sarcomere. I do think it is part of the sliding filament mechanism. I do think sometimes it's the sarcoplasm, and I think sometimes it's the sarcolemma. I think there's different parts to that. I have a really hard time trying to figure out how people could break apart the myofilament that specific. But when it works in the arena of 124, so 124, 46 torn and broken on, say, the muscle fiber, we know that that would work. Torn and broken on the sarcoplasm wouldn't do anything. However, when we did our little study with running like a DOMS type of, or a delayed onset muscle soreness or post-activity study, where we're just measuring girth. So after, especially hockey players, after they play, their quads and legs are huge. So it's all full of muscle byproduct in there. So running 40, or running in that scenario where you're running inflammation, it wouldn't be inflammation in the sarcomere. It would more likely be inflammation in the sarcoplasm and the sarcolemma, like the gelatinous structures start to deflate. Same with
congestion.
And we've run congestion, especially congestion in the fascia. So I am reconfiguring like the DOMS and the post-workout type of programs, especially depending on what's at play. When you have DOMS, when you lift weights or you go for a run, goodness knows I could barely get out of bed the day after the half marathon, because I had torn and broke a whole bunch of things in a good way. It wasn't a fracture, it wasn't a sprain strain, but you have micro tearing when you exert yourself. Sometimes that causes pain. So I find that the DOMS protocol, sometimes you need help with the pain, but sometimes you can do something right after the activity, kind of prophylactically, so that you don't get sore.
DOMS protocol study was done immediately after the exercise to prevent
Yes.
delayed onset muscle soreness. And the nice thing for us is there is no thing that will prevent DOMS.
No.
The next time, like the name tag just flipped to Dr. Mung, the next time you run a half marathon, you go home, you climb in the bathtub, and you run your enhanced DOMS protocol. That is 46.
And I'm normally very good running these things in all my training. But like I said, after the race was over, I forgot all about my body and was just living up in the clouds for the rest of the day. You know how that goes.
Endorphins will do that.
Yes. Until the next day where you're just like, darn it, I knew I forgot to do something yesterday.
And we can't walk today. Oh dear, tomorrow's going to be worse.
Yeah.
You can always climb in the bathtub and fix it. 124 has turned out to be
magic. I don't know. Do you think we'll find more frequencies are going to be time dependent?
I have no idea. This is one of those things where you have to say out loud, it's not like we know what we're doing.
Yeah.
With 124, I had never used it ever. And Kathleen Casman, who is on the list of people where are you? There's Kathleen. She said, I asked her if she'd work on my Achilles because it's when I was able now to move my hip after my left hip was replaced. My left Achilles was just, after a year, I've been treating it for inflammation, and we worked on it, and it was never pain-free for more than 15, 20 minutes. So this is now 10 months, and Kathleen, we're still wearing graphite gloves back in 2009, and Kathleen has graphite gloves, and she puts her hands on my ankle, and she says, this feels yucky. And all of a sudden, the gloves get warm, and she's moving her hands. And I said, what are you running? And she said, 124. I had never used it. And in 60 minutes, my Achilles went from 2 thumbs, can't touch it, can't work on it, to the bag, and never need another treatment. That was 2008. 2009. Who knew? So I think as we practice, same thing with these investigational frequencies. I had no idea. I mean, the cons used to be investigational. Now it's standard. Okay. And trigeminal nerve is working its way that way. And who knew?
I think what's great now is we have this like really great big community that people can try and share and report back and see what's happening. I can't see any of the Q&A, but I want to make sure that we're getting to them. So I'll leave that to you today.
I fussed at Joanne. Oh, he didn't bring the custom care with me on vacation.
Oh, that's silly.
He said, I will do better next time. Yeah, you're never going to forget it.
No.
It would be like me traveling without a CPAP. It's just shoot me. Brain-derived nerve growth factor as a homeopathic. I have trouble with homeopathy, but that's personal. What's interesting is BDNF is increased by the vagus. So as you're treating torn and broken in the periphery, it's those little tissue fragments, the damage-associated molecular patterns that are floating around that turn the vagus down. The BDNF, if you look at that slide about the vagus increases all the good stuff and decreases the bad stuff, the vagus increases BDNF. So, but for those of you for whom homeopathy works, Dad says that there's a homeopathic BDNF something, and that's just, for me, I'd let the vagus do it, because the vagus and the brain will decide how much I need. Eye care. Okay, is anybody out? Yeah, Julian just agreed. There's a challenge I have with the eye care, and that yes, it works. The frequencies work. The magnetic field is really weak, and it doesn't work for everybody. And there are some things that flat out doesn't work for, especially if somebody's like big. It has the advantage of being really portable and being affordable. And the bad news is it doesn't have a 510K. JJ did get, I pulled a Dr. Mom on him, so he did get liability and product liability insurance. So it's worth a try, especially if a patient can't afford a custom care. But it depends. Keep in mind the size of the patient, what they're going to do, and that's a good thing. Refresh the newbies on what the frequencies that you mentioned are. Repetition beyond the obvious, 40 and 81. So 46 is sarcomere or muscle as a tissue type, which could include all of the sarco things, the sarco something you were talking about. 77 is flat connective tissue. 191 is round tissue. 10 is the spinal cord. 454 is the pons. And you just have to look up where in the brain it is and what it's supposed to do. I didn't realize that if you had a pons stroke, that you got spastic all over. So this lady has a right cavernous hemangioma that remains in her right pons, and the right side of her body is tight. And then at the very end, she's one of those that says, "Oh, since you did this, let's do that." No, it's 5:00. I've got to go home. I can't do anymore. But what was interesting was she was really stiff. Some of that was the pons, but what I ended up treating was scarring in the dura. Thank you, Eduardo, wherever you are. So treating scarring in the dura, all of a sudden this tight catch in her hip went away. And I grabbed, because she said some chiropractor had yanked on her neck, and it felt so good. And I went, "That's scarring in the dura." She said, "What?" I said, "Lay down." And we ran from her neck to her sacrum. And I ran scarring in the dura and just got under the base of her skull and just pulled. And then I went down to her legs and moved her legs up toward her chest and had her tip her head down, tip her head back, turn her head. And she said, "Oh, my hip doesn't hurt anymore." It's because the dura attaches to the tailbone.
Right.
Yeah, everything is connected to everything.
And in September, I get to hang out with the Irish people and talk about fascia. So the Dublin course is, I think, sold out already. So that is super exciting.
Wait, are you going to be in Dublin in September? What date?
27th, 28th.
Because we're going to be in Rome. You could have come over to Rome afterwards. Christy Hughes is lecturing in Dublin, and she said, "I'll come to Rome afterwards." But they're so close. It's an hour and a half flight.
I know, it is super club.
I'm so glad you're so
exciting. I didn't have much to do with it. NTC did all this stuff, but I think the way that they're trained, thinking about fascia, everything is connected to everything. That type of mindset really does help with FSM, because you stop being so myopic. It's not just the shoulder. What's the shoulder connected to? The ribs, the neck, the diaphragm. It's everywhere.
Psoas quadratus femorum. Do me a favor, just remind John Starkey that the fascia is innervated. You
I will.
treat the fascia without treating the nerve, because the nerves run in a nerve-fascia sandwich, and scarring in the nerve will change the tone of the fascia.
Yes.
And even as John Sharkey is looking at me in the face, I will say that fascia is innervated.
Yes. And we're learning. I can't wait to bring a whole bunch of Peter Twist fascia research and say, this is what the Canadians are saying. So you have to listen. But we know that treating the nerve, that I really do believe when somebody is in pain and they come in and you treat the nerve, whether it's with 40 or 13, inflammation or scarring, and you get that instant sort of relief, that warmth, that smush, the tissue relaxes. And I do believe that is the fascial response. I do think that's what we are feeling. Thixotropic changes in the fascia is what smush is.
By the way, speaking of thixotropic changes, today I got invited to what hospital is he with? He is with a hospital, and there is a biophysics conference in, where was it? The chair of emergency medicine at North Shore University Hospital. And next April, there is a biophysics conference in Washington, D.C., where everybody that's anybody, including, what's his name? The Vegas guy.
Gorgeous?
No, the real Vegas guy. Sorry. Yes, Steve, what's his name? Has a Kevin helmet. I want to say Kelly, but that might not be correct. Anyway, his name is on my fascia diagram, and he's the one that published the original work on how the fascia controls the neuroendocrine immune system. And he's the one that runs the Feinstein Institute for Vagal Nerve Research. And bad news for him, because he wants to develop an implanted vagal nerve stimulator, and we are the first ones to do the research and get a plan on an external vagal nerve stimulator because of what the frequencies do. And then people are going to be invited to do poster presentations, and he suggested, because everybody in the biophysics world is pretty close to my age, we're all in either late 60s up to 80, and he said, bring somebody younger who can do a poster presentation. So I'm gonna perhaps be obliged to warn you that April of next year, it is April 13th and 14th, there is a quantum biology forum in Silver Springs, Maryland. You'd put that on your calendar.
Yes, sir. Do it right now.
There you go, right there. And then it sounds like it's going to be a relief.
Yes. Amazing.
I mean, crazy as I'm going to remember his name as soon as we turn the
100%.
tape off. Yeah.
What happens?
There's a substance thank you. I know.
And I'm sorry for my very silly computer that couldn't find my microphone or my speaker.
The internet. Don't forget the times that it forgot the internet. It just needs a little rest.
It does.
It is.
Or it needs replacing. I will threaten it.
Well, we're going to fly Kevin down, and Kevin stand.
It better behave. Yes.
It will behave.
Very threatening.
Congratulations on your half marathon.
Thank you. Thank you.
FSM had the uphill.
Yeah.
Screen.
Yes, it was great. Very fortunate to be part of it.
And to everybody that's listening, the Advanced in Phoenix, March 19, 20, 21, and 22. I need case reports and poster presentations in the afternoon. 4 days, you guys. I got 4 afternoons to fill. I've got Juliana Mortensen, Jay Shaw, David Musnick, you. I haven't told Patrick Wood that I'm going to ask him to present, but he's probably going to do that. And then probably John Ruskey, because I will keep drumming vestibular injuries into people until they actually, that's the second thing they think about. And maybe that the surgeon that you talked about, I have to contact him.
Yep.
But case reports. That's everybody here has case reports.
Yep.
So. Oh, and Karen Perry got an Ehlers Danlos case published.
Amazing. So many amazing things on the horizon for us.
I just love our family.
So do I.
Yay.
Okay, that's it for today. And we'll see everybody here. I will be much more prepared with the working speaker next time.
It'll be fun.
It'll be fine. It always does.
Great.
All right, everybody.
Bye, everybody.
See you then.
Love ya.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.